This is No Operating Manual, a podcast about building healthcare companies when there's no one clear path and no operations manual. My guest today is Emily Olson, head of clinical operations at Braided Health, whose career started at the bedside as a nurse long before startups entered the picture. She's worked across nearly every layer of healthcare, from direct patient care to scaling digital programs at early stage companies. And today we'll talk about how you build systems for patients and members with complex needs. Emily, thank you for being here.
Thanks for having me. I'm excited to be here.
Well, let's get into it. So you started your career as a nurse. Did you always expect to move out of direct patient care, or is that something that kind of developed over time?
Yeah, I didn't have a lot of expectations at that point in my life. I was barely planning 2 weeks ahead, let alone my career. So I kind of just went with it and had some opportunities presented to me. But once I got a little taste of being able to design systems and having an impact for a much broader range versus just one patient at a time, I was pretty much hooked.
That totally makes sense. You spent some years inside large, complex healthcare organizations before moving into early stage companies like Evergreen Nephrology. What felt most disorienting when you stepped into that startup environment?
I think for me, not being handed a playbook and having a vague job description was pretty surprising. To be honest, when I first joined a startup, I don't even think I really knew what that was or really knew that I was applying for a startup, but it became very clear when they said, "Oh, you have a great background. We think we should use you, but we don't know what you're going to do with you." And I don't know that I would say it was disarming. For me, it became thrilling. So that was kind of the first time that I realized that this might be something that I was into. And I think I was probably right, given that I've been doing it ever since.
So, what sorts of things in those environments, again, moving from large to startup, were the things that they kind of threw at you because they're like, oh, this is something that someone with your background can handle?
Yeah. Well, I think the whole role, so at that time I was a behavioral health care manager, and they knew it was an important part of complex populations in managing health. But they only had one other person in the entire company doing that. And so it was really up to me to learn very quickly how the business worked and I actually ended up making a quasi playbook for the role and figuring out, sort of thinking about what I knew about being a case manager and what I was learning about value-based care, and thinking about how can I help others to kind of come into this and move into that understanding more quickly. So I ended up creating a little bit of a playbook, which I think kind of helped me to progress later in my career, even though I wasn't necessarily doing it for that reason. I like to have a playbook for myself. So it was partially for myself, but it ended up being something that could be used more broadly as well. So they wanted me to think about, how do we recognize which types of patients would be best suited to be managed by me? How do we document? How do we make a plan of care? How do we integrate with their other providers, both within our agency and in the broader ecosystem, to really make sure they had that continuity of care and that there was good communication, goals were aligned, and that we were able to successfully meet our mission in the company.
So when you were doing that, so in terms of like, how do you digitally document, especially with those external agencies that you have to work with, what sorts of things did you have to be mindful of or be aware of at the same time that you're building that playbook?
Yeah, I had to be aware of, well, at that point, in psych, we were still doing a lot of paper documentation. And so when I first joined the organization, we actually had two different systems that did not talk. And so we were doing a lot of, and this is not anyone who's listening who's been there, done that, knows that this is not uncommon. And it's still not, this was 10 years ago plus, and this is still happening today. This is something which when we start talking about what I'm doing now, we'll give a little more context to it. But really thinking about what information needs to be documented, what information may need to be documented in different places. So oftentimes, if someone had a complaint or a grievance, we couldn't put that in this chart. We had to document it elsewhere. Really coming to understand, how do you document enough details so that someone else who might need to understand what's going on with a particular patient can know, while not making it so onerous that they're wading through lots of narratives about the cat and all the hair on the couch or all these types of things. And so really understanding how to be both concise and detailed enough to sort of meet the need. And that came over time and working with others and getting feedback about that. That was not an instantaneous thing that you know how to do.
You mentioned earlier about building that playbook so that someone else could step in and kind of follow that playbook as you grow. From a team perspective, you've managed large teams and smaller teams. Does your approach change based on the stage of the company or where that playbook is?
Yeah, my approach does not change. The way I execute it does. So when you're a very small company, it's both easy and effective to do a lot of hip to hip, over the shoulder type coaching, probably longer one-to-ones. And I recognize that that literally was not sustainable when you have more than 200 people reporting up through you. And so you have to create a system that allows that same level of thoroughness, make sure that those relationships are cemented, but understanding that that can't come all back to you. So I was really insistent on doing regular one-to-ones with the team. And this is not a sponsored plug by any means, but there's a great set of tools called manager tools that I've used for a long time now. And they give a very clear script of how to divide a half an hour one-to-one in different 10-minute segments, which allows a lot of time for feedback as well as time for career growth conversations, which I found to be part of the probably the most effective piece in being a good manager because it really allowed people to share what they're passionate about, ways that they'd want to grow. And then from the manager standpoint, you're really able to think about, okay, how might I be able to use those skills or find opportunities to A, help get work done, especially in a really strapped startup, and B, also provide opportunities for people to stretch and grow and start demonstrating abilities, maybe for a promotion, but maybe not. And so once that framework was solidified, then I can start expecting the people that were reporting up to me to also be having those same conversations with their teams. And so it's again, it's just more about the execution than the approach. The approach is always the same as really keeping in touch, knowing, very similar to patient care and knowing what motivates your team and how you can kind of align incentives and goals and motivations so that everyone's kind of singing off the same page of music.
I love that. I love getting that consistency down for sure. At Braided Health, your core product is wraparound care management technology for dual eligible and LTSS members. From an ops perspective, what changes are required to support high need members?
Yeah, I think the biggest one is the duals piece. So, what we know about duals is that only 7% or so are actually receiving both Medicare and Medicaid benefits. Just for the audience, if you don't know, duals are people who are receiving both Medicare and Medicaid benefits. And the thing that makes it more difficult is that not only the complexity, the different types of challenges these folks have, but also the fact that only, again, around 7% are receiving both of those services from the same entity. So you think of Aetna or Humana or these big ticket players. And what that means is that oftentimes those who are trying to help people manage their care are seeing less than half the picture. And you can imagine if you have these siloed entities both trying to do the right thing, but they aren't necessarily fully aware of what's happening, let's say on the other side of the fence, that can cause two major things. Both are problematic, either redundant services. So time and effort and money being spent on the same thing that's not necessarily driving additional value and or gaps in care where someone might think, oh, well, this is probably covered under their Medicaid benefit, or maybe this is covered under their Medicare benefit. And this is not necessarily for lack of trying, but when you don't have all of that data in the same place, it's very, very difficult to manage. And you can imagine if you don't fully have comprehension of what all the problems and all of the drivers are, it's really, really difficult then to effectively change outcomes, which is really the goal of most people or most companies in this space.
So just so that clear for people who are listening, you're saying that only 7% of D-SNP plans are fully integrated plans.
That's right. Yes.
Okay. So that 93% have two different insurance companies managing their healthcare with two different streams in terms of care management or any part of that care process or
That's
that
right.
member engagement. That's interesting.
Yeah.
I didn't realize it was so. That's
Yeah. And
That's
there's a
shocking.
lot of, for obvious reasons, hopefully that's quite clear now, there's a lot of momentum from the government and other key stakeholders to change that because it makes a lot of sense. And it's probably not a surprise that when you have the bigger picture, then you can much more effectively figure out, you know, what are the scope of benefits? Where is this best covered? What is the best intervention mix so that we're not only avoiding costs, which is important. Sometimes we don't like to talk about that in this space. But at the end of the day, if we're wasting money, then we don't have that money to spend on the things that really matter. So cost always matters. And it's not, that's what's really cool in my mind about value based care is that cost matters because we want it to be receiving the right care. And that's where I think of a Venn diagram where you have all of the stakeholders and you have that middle space where we're saving money, we're aligned with the patient goals, values, and preferences. We're looking at making sure that we're not using things that maybe don't make sense because of other diagnoses that they have, you know,
Mhm.
mental health diagnoses, those types of things. And so there's a lot of different layers that we can apply to really figure out what is the best intervention mix for this individual. But we can't do that unless we have all the right data and we can see that full picture.
Got it. No, that makes absolute sense. In your current role, you're head of clinical ops. This title could mean something really different depending on the organization. So, for a company like Braided, early stages, what does this role entail?
Yeah. So the simple answer is anything. My job is really to make sure that we have clinically sound programs that make sense from a technology and business standpoint. But what that means in function when you have about 4 FTEs is that there's a lot of things that fall under that. So the core part of my job, and for context, Braided is a software as a service company primarily, and we do offer some teams as well to support that. But in that, what our primary objective and what I've spent most of my last of the 2 years doing is really figuring out how is care management best executed and how do we need to change the tools that are available to the care managers or social workers or service coordinators or care coordinators? And how do we make sure that those tools are driving towards the compliance needs, the regulatory requirements, best practice of care management needs, all of those things to make it so that the teams are not constantly in fear of messing up or missing something because things are always changing. You might have a different approach to one patient who has a particular sort of coverage versus another, those types of things. And those things basically become impossible at some point to keep in your mind, let alone, you know, patient centered care or those types of things. And so, really figuring out how do we take what we know about what needs to happen, what's happening today, and how do we create and leverage software in the appropriate ways to make it easier to do the right thing and harder to do the wrong thing. And that's where we've really focused our platform in the last couple of years in the development of it.
It's really kind of an integration or a prioritization around care and compliance. Like, how do you make sure
Yes.
you're compliant, but also providing the right care with the
Yeah.
tools developing? So that sometimes can, bump up against each other. But
Yeah, and it really shouldn't because at the heart of most compliance things is because it is the right. But we have spent so long in this sort of like competing priorities. Everything feels like a check the box activity that we have started to lose the ability to sort of see the forest for the trees. So
mm,
thinking about, okay, we have to, do a health risk assessment yearly. A lot of times that feels like a drag. We're getting it done just to get it done. And we forget that the idea of those is really to determine what is the drivers of risk in this person and how do we address those. But those things become sort of disconnected in everyday workflows. So, what we're really trying to do is saying, what are the questions we're asking? How do we make sure that that connection actually is reinstated so that it A, doesn't feel wasteful to the patient? Like, why am I even asking these questions? Because it doesn't appear to affect the way I'm being cared for in any way, and the care team members. And so, once you're able to reconnect that and say, okay, we're using the assessment to identify what things are preventing you from meeting your health goals. Let's now talk about how we're going to address those things in a way that's aligned with the things that you care about. So instead of talking about A1C or blood sugar management for diabetes, we're still going to talk about that, but we're going to talk about it in a different context. So we're going to talk about it and say, okay, Mrs. Jones, I know that you told me that your real goal at this point is to be able to continue to get down on the floor and play with your grandkids. You have 5 of them, many of them aren't walking. And so that is your realistic goal, is you want to remain healthy enough. And then you can start talking about, let's talk about your diabetes, one of your diagnoses, and that isn't under control. The risk here is that you could risk blood clots or the need for amputations, which is really going to impede the ability to do that. So let's talk about how we can remove some of the barriers and get you doing better on that. And a lot of the interventions end up being really the same, but when it's aligned with someone's own motivation, you've sort of removed an unnecessary barrier. There's plenty of barriers in the world that exist. And so this is one we can actually pretty easily remove. And technology is a huge part of that.
Yeah. Yeah. Connecting the two. All right. Closing this out. If, even thinking about yourself as a young nurse, if you could talk to a nurse or even a clinical leader considering their first startup role, what do you wish someone had told you earlier?
Yeah. I think I'm maybe glad no one did tell me this earlier. Honestly, I like the naivety. But what I talk about is a couple things. I talk about when you're approaching a startup role, it is much different than approaching a role in a bigger company, because more likely in a bigger company, you are entering a role to do that job. In a startup, it's much more likely you're going to end up doing something else. And that can be really exciting for people, because that means traditionally faster growth, more opportunity, but it can mean a lot less stability. It can mean compensation looks a lot different. So a lot of new startups, you aren't going to come in making the salary of your dreams, right? But there's other benefits like I just talked about, as well as equity components, which I knew zilch about. And so really making sure I actually talked to the last year, I've talked to a lot of people who are kind of thinking about the clinical to or bedside to boardroom type transition. And I asked them to really set some boundaries for themselves and understand, like, how much do you really have to make so that you're not putting yourself in a risky financial situation and you're going to be comfortable enough. What is your sort of tolerance for risk? So when you join a startup, understanding where's their funding coming from? Like questions, especially as a newer person, you're not typically answering. And how much runway, how long can they support you in this role? And what is your tolerance? Do you need 6 months? Do you need a year? That type of thing. And then I think the last piece is really understanding, are you the person that wants to walk in and have the job laid out and you to execute against that? Or do you want to come in and forge your own path? I think it feels sexy to say the latter, but I think there's definitely a lot of people who it's just not the thing for them. And I ask them, and also recognizing that, especially if you're joining a company that's talking a lot about innovation or change or these types of things, you also have to understand, even if you're a very seasoned, and more so if you're a very seasoned nurse or social worker or executive, you have to understand that innovation is not just changing healthcare. You have to change a lot of the ways you've probably done things. And I think that's not necessarily something people think about, that, what got you here won't get you there type idea. And I think that's something that I really challenge people to think about and have an understanding of as much as you can without actually doing it before considering the startup space.
That's a really great insight. So it's not just about changing the processes, it's about changing how you think in order to get that process change. So, well, I appreciate your time, Emily. Thank you so much for sharing your wisdom and your experience with us. And I'm looking forward to sharing this with everybody else.
Yeah, thanks so much, Erin. It was great to see you.
Yeah, you too.
Thanks for listening to No Operating Manual. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and a review, and don't forget to subscribe on YouTube. No Operating Manual is hosted and produced by Erin O'Brien of Chemistry, a healthcare marketing and communication advisory. Visit our website at choosechemistry.com.